Good morning, everyone. Welcome to our webinar this morning on getting patient information to the next setting of care. I'm Martha Chill. I'm the CIO at Wellmont Health System, and this is the first webinar that is being hosted by the Community Collaborative on Care Coordination. This group was formed a few months ago to focus on sharing information, patient information in our region. A couple of things is that we're going to do the presentation today, and then we'll have time at the end for questions. I'd like everyone, if they take just a minute and make sure you mute your phone. Also, please make sure you do not put us on hold, because that will then put us on mute and not allow everyone to hear the presentation. So please just put us on mute. And I'm going to go ahead and let Dr. Russ Lethbridge kick us off this morning. Dr. Lethbridge is the Senior Clinical Advisor for Interoperability with InterSystems Corporation. But more recently, he spent the last 5 years as the Chief Medical Information Officer for the state of Tennessee. And it was actually Dr. Lethbridge who initiated this with us in Northeast Tennessee to form this Community Collaborative on Care Coordination. So, Dr. Lethbridge, if you'll go ahead and begin.
Thanks, Martha. Hello, everyone, and I'm glad you can join us. If I can have my first slide, and as we're going to talk this morning about some of the activities in the Northeast Tennessee region that demonstrate, I think, that getting information to other providers in a timely fashion is possible and is possible today, and we hope to encourage spreading this around the community and to a wider range of providers. I think everyone knows that the transitions from the hospital at discharge or from the emergency department are a frequent failure point for care coordination. The information about that hospital admission or discharge, emergency discharge doesn't get to the next provider or next setting of care or doesn't get there in a timely fashion and winds up with record requests that take days or even weeks to get a response. And in fact, this is not a problem just in Northeast Tennessee, as I'm sure you know. It's a nationwide problem, and a study a few years ago showed that when a patient who's been discharged from the hospital sees their primary care provider for the first time, 75% of the time that primary care provider does not have the discharge summary when they see the patient. The next slide, please. And the solution, or one solution to this, that has been part of the health information technology transition taking place the last few years, is an electronic document generated from electronic health records at the time of discharge, and that's really becoming a standard of care around the country in many places. This document, electronic document, is referred to as a continuity of care document, and the latest version of this, fostered by the federal programs, is called Consolidated CDA Summary of Care, but it's a newer version of that CCD document. Oops. Back one more. Thank you. So what is this clinical document architecture, or CDA, and why should you care? Well, CDA is an information technology standard for creating an electronic file in which all the enclosed information is both in human readable form and can be displayed on a computer screen or printed out, but it's also there. Critical information like the medication list and problem list are there in a computer readable form that can be incorporated into a patient's record or used for decision support or analysis. So my analogy for how this works is that these CDA documents are made up of information Legos. There are actually 9 different document types in this standard for producing these documents, and one of those is the CCD, or sometimes referred to as a summary of care. It contains Legos that represent the problem list, the allergies, the medications, and other important clinical data concepts. And the most important thing is that every EHR vendor in the country and every other information technology vendor gets the same set of Legos. So sending these documents to another system that has the same Legos means that those information Legos can be pulled out and used to do medication reconciliation or otherwise in the course of patient care. So with that, we'll get started with the first of 3 case studies that you're going to hear about this morning. The first is the discharge of a patient from the hospital to a community provider. The second, where the provider is affiliated with the hospital and has a slightly different electronic connection. And the third, very importantly, is sending the same information to a long-term care setting where there's often not an electronic link and not an electronic record, but in this case it's still possible to send information in a form that can be accessed on the internet. So with that, I will turn it over to Trish to tell us about the Nurse Managed Community Clinic in Johnson City and their experience with transitions of care.
Thank you, Russ. I'm excited to share some history about nurse-led health centers in the area and the effects that messaging has had on the care we've been able to deliver at the health center level. First, for those on the phone, a little history on the Nurse Managed Health Center, the type of care that is focused on and the population that is served between the hospital and the health center. Nurse Managed Health Centers provide primary care, health promotion, and disease prevention to individuals with limited access to care. These clinics provide care to the vulnerable populations in America's rural, urban, and suburban communities. For many patients in medically underserved areas, nurse-led health centers and nurse practitioners are the area's only primary care providers. A major goal of the health center is to serve as a critical access point to keep patients out of the emergency room, saving the healthcare system millions of dollars annually while providing quality primary care. ETSU and the College of Nursing have been a leader in the nurse-led health centers for over 25 years. The nation's 250 nurse-managed health centers record more than 2.5 million patient encounters annually and have the capacity to serve millions more. The model of care emphasizes wellness promotion, disease prevention, and the management of chronic conditions such as asthma, hypertension, and diabetes. Many also provide dental, behavioral, and mental health, health education, environmental health risk reduction, and parenting education services. A NNCC, which is the National Nursing Center Consortium study of 11 of these centers in Pennsylvania, found that these centers are of critical importance as safety net providers of care for the medically underserved. In the communities where the nurse-managed health centers have been established, they have a reputation for providing that high-quality, cost-effective care and achieving high patient satisfaction rates. Next slide, please. Let's define the transition of care. The term transition of care describes the scenario of a patient leaving one care setting, whether that's hospital to nursing home, hospital to the PCP, home health, or just moving to another area. The highest quality level of care was being compromised by the lack of coordination between these areas. As we know, healthcare is a complex, fragmented, and discontinuous system that provides opportunities for systematic failures and can adversely affect the patient's safety. The lack of continuity of care was occurring during the transitional phase of care from the hospital to the health center and the health center to the hospital. This was due to multiple factors. No direct communication was being done between the hospital and health center, and the patient was not delivering the discharge paperwork from the hospital or the ER to the clinic. Also, if the health center received the discharge paperwork, the complete record would take 48 to 72 hours for the health center to receive from the hospital system. On the other side, the hospitals were just as frustrated, as they had very little knowledge of the patients from the direct admit to the obstetrics patient. It became very evident that a goal was to find a way to provide seamless care with a smooth and safe transition for the patient. Good communication between patients, caregivers, and providers, and a comprehensive transitional care plan are crucial for successful medical management. The advancement of seamless care was reachable by both the health center and the clinic due to the technologies in place that opened up communication between the facilities. Next slide, please. I pause in all of the episodes of care as a patient who, with sufficient education and empowerment, can proactively facilitate necessary communication and interaction between providers. It was identified quickly that the two care settings, the hospital and the health center, were serving a number of the same patients. These patients are least likely to receive ongoing health care services. This population includes people of all ages who are uninsured, underinsured, or living in poverty. These patients face significant challenges when moving from one care setting to another with fragmented healthcare systems. As a group, we knew that not only can poor transition lead to poor quality care, transition of care issues pose a financial burden for both the health insurers, the government, and patients. In order to improve the health care in this region, patients and providers must ensure better information exchange at all stages of the healthcare process. Next slide, please. A task group of the State Health Alliance, Medical Records and IT Group, the ETSU Community Health Center leadership, IT and Health Center directors, and then Russ Lefkowitz were assigned to now make it work. I know that as a team we were hopeful for any transition, but we did have to overcome several challenges, such as the patient had to know their PCP. Most often, they would know the name of the health center, but not their direct PCP. The clinic worked on educating, while our colleagues figured out how to capture the data. The second challenge for both teams was time. Once the CD files had all the information that the health center needed, the workflow issues for both the hospital and the health center, a final decision of a batch per day was made, and the health center assigned the direct message to one address that would disperse to several contacts. The third challenge was internal to the health center. The data was being received but could not be directly attached to the record. The workflow was adapted several times with printing and scanning to the record for the nurse practitioner to see. The direct messaging concept began to form, and we slowly saw how it would address the gaps in the transition of care. From these challenges, we have successes, and we've seen a decrease in the delays of records being received, and the transition for the patient is smoother, as well as we have established a continuity of care between two levels of health care in our region. The continuity of care has minimized the delay of discharge visits. There's a strong security and privacy with the CCD, and there's a one unified standard that both systems have been able to leverage. The improved communication between providers, efficient report exchange with no delay of crucial information, and the ease of sharing patient information have been great successes. I want to point out we'll be able, as the next workflow that the task group will be able to move forward on, is the ability for the health center to send CCD or CCA to the hospital and directly adapt these files into the patient's records from the hospital itself, which is a key success. Overall, the success has led to the benefits for both locations. I believe and have increased the quality of health care that the health center is able to deliver, and has helped us improve our practice workload with minimal delays to patient records, and has reduced extra medical testing as we now have the results from the hospital at our fingertips. And as direct can be incorporated into a variety of interfaces from email to mobile devices, I believe that advances will continue to broaden the scope of what can be done. In conclusion, the future of furthering the direct messaging and collaboration of care is at our fingertips, from health center to hospital, to peer-to-peer collaboration. This progress is only the start of bridging the gap for the care of our patients while reducing health care costs. Thank you.
Thank you, Trish. Appreciate that. We're now going to move on to our second case study. This relates to hospitals and physician office collaboration. And our presenters here are Chip Childress with Mountain States Health Alliance IS Manager of Advanced Ambulatory Applications, and Dr. Jeffrey Merrill, who's the Medical Director for Mountain States Medical Group. So I think Chip is going to speak first.
Yes, good morning, everyone. I'll start out with some of the challenges that we've had in front of us as we work to share information back and forth between our medical group at Mountain States Health Alliance and the ED within our system. Our needs really were we wanted the physicians and patients to get the right information in the right place at the right time. I think that was the underlying concept of what we kept hearing from our user base, that we really need to have information in some way as much as possible. Our emergency department wanted information from ambulatory physicians, and ambulatory physicians really needed to understand when their patients had been seen in the hospital. So, and then for the patients, obviously the most important piece of it is the proper follow-up after the visit to the ED or a hospital admission. So, all those things are needs that everybody has, not just Mountain States Medical Group. And so as we were working through this, we wanted to not only deliver a solution that worked for our medical group, but also that would be universally accessible to other entities in our area that the physicians had a need. So, sometimes it's difficult to deliver that concise information and have it there in a timely and standardized way for people not have to go and search and try to extract it. So we wanted to try to reduce that or improve that experience. Obviously, in our case, we have two different EHRs, one for the ambulatory group and then for the physicians group, and one for the hospital. So we were sharing information between two disparate systems, two different vendors were providing that information back and forth. And then we also still had to meet the HIPAA requirements, that the minimum necessary was there. So we really needed to work from an IT perspective to validate the relationship with the patient, the ED, and the ambulatory physician actually existed. If we wanted to do this, but that wasn't high enough bar. We also wanted to do this with basic no truly custom interfaces. We wanted to use a lot of the technology that has been delivered in our EMR packages through the meaningful use standards, as Dr. Lessons talked about earlier, the CCDA technology and direct messaging. Next slide, please. So this is a sample flow of what actually happened. When you really break this down, one of the asks that we had was our ED physicians wanting information from ambulatory physicians so they can actually see that information as the patient presents to them in the ED department. And then from the physician side, the ambulatory physician side, they're really wanting information back. My patient's in the hospital, they'd like to know that in a near real-time basis. And then while they're there, you get a discharge summary at the end of the day when that patient leaves our ED or our hospital. So to establish the relationship, the patient presents the ED, and as Trish mentioned earlier, one of the challenges is we need that patient to identify their PCP. That allows us to say, yes, there's a relationship, and the patient gives us permission to share information back with their PCP, again, meeting some of the HIPAA requirements. Our system actually validates that relationship exists by having that information, and then while the patient is actually in the ED as they're presenting, our ED system, our medical record system, actually can reach out electronically and make an electronic request to the ambulatory physician's EHR for a CCD. And so the system generates it on the fly, takes about 30 seconds, and it will then send that back to the ED system. And it actually populates that into what we call our tracking board, and actually provides an icon to that care team to let them know that there's actually additional information from that ambulatory physician available for their review. And it's a concise document, the CCD that Dr. Lessons talked about. That's what's being presented, and it's presented in a standard format. Pretty much no matter what system it comes from, it's going to have the same content and a very similar look and feel. The ED system is also generating a message back to the ambulatory physician physician to say, not only I got CCD, but we have your patient in our facility, and here's where, and kind of give an ongoing status update. So if they are brought in, it lets the physician know if they are discharged, it lets them know that they're discharged from the ED. If they move to an inpatient status, it provides an update that they're now moved to an inpatient status. And then once they're discharged, ultimately from the hospital, if they were admitted, it sends that discharge message also. So this ongoing almost dialogue between these systems is providing running updates to the provider about what's happening with their patient, the ambulatory provider, what is happening with their patient. And then upon discharge, the CCD is then electronically sent to the ambulatory provider through direct messaging. And we believe, as Chris is talking about, and everyone's talking about, that direct messaging is super critical to making this happen. It's a standard way of communicating. And then ultimately, it's up to the physician, that ambulatory physician, how that EHR deals with the information. And they present that in the document. If they can look it up in a browser, or the EHR may actually consume that data and display it as discrete data within their system. So there's a lot of flexibility, really controlled by the ambulatory physician. So when you distill this down, and we'll go to the next slide, when you distill this down, we're really talking about, two acts. One for the ED physicians, I'd like to have information from the physician, the ambulatory physician, the CCT of the patient. What is the current state for this patient? And then from the ambulatory physician side, that request back to, I'd like to know my patient's there, and also what was the ultimate outcome for that patient. That's what we've been able to achieve so far. We've done that with our own physicians. And then we have actually been able to, for the next step here, one of the things we actually have done is the inpatient care team can now see that CCD, so that they make the transition into other areas of our facilities, so everyone can see that information, so they're with a clearer and fuller picture for the patient. Our next step that we're already working on is to actually work with clinics external to the United States, so that we can demonstrate that not only does it work internal to the organization, but that it is a universal solution that we can work with other physician groups to do, and again, meeting those same asks and returns of information. And finally, having more systems that will electronically digest information, so that not only are we providing a document, but electronic systems can actually provide more input to the physician, maybe be able to show, from a metric affiliation standpoint, different issues around those medications. So, some good things coming, and next steps. Next slide, please. And finally, CFN, this is actually a CCD that has been generated in our system. It's a test tracing, as you can see, but it has a full complement of information, and just like Dr. Leftwich outlined, it provides the standard kind of content that you would expect upon discharge. And next slide. So now I'll transition this over to Dr. Jeff Murrow. He can speak more to, from a clinical perspective, as a physician, what this means to them.
Thanks, Chip. I just wanted to share a little historical perspective on the electronic medical record. Almost 50 years ago, back in the 1960s, Dr. Lawrence Weed introduced the concept of an electronic medical record. Over time, these systems had become increasingly complex with HIPAA regulations and technical limitations, had made it very challenging for EMR systems to share information. But the recent advance with the electronic CCD exchange now allows sharing of this data between EMRs like Chip and Trish have gone over. Next slide, please. For providers, some of the benefits of sharing this data are the more efficient and effective sharing of patient information across the continuum of care, leading to improved quality of care and improved outcomes, better decision-making at the point of care, reduced medical legal risks, which are commonly associated with inaccurate or unavailable information, reduced time for providers and their staff hunting down information, improved opportunities around shared savings by reducing the total cost of care. One common example is the sharing of data allows for better handoffs around care transitions, leading to decreased hospital readmissions. Next slide, please. For patients, some of the benefits of providers sharing this healthcare data are when providers share information more efficiently and effectively, patients receive better care. There's better care coordination across care transitions. Patients are more likely to receive proper and timely follow-up care when the primary care physician is aware that the patient was in the ED or recently discharged from the hospital. There are less things for patients to remember to tell their providers about their recent interactions with their healthcare system. Reduced risk of medical errors, such as drug-drug interactions, when one clinician knows what the other clinician has recently prescribed for the patient. Reduced cost of care, like we talked about, also related to things such as redundant testing. And there's less paperwork for the patient to manage, which is very important, especially for people, homeless people and others that are very challenged with carrying documents from one provider to the next. Next slide, please. So we're still a long way. We have a long way to go, and the technology is far from perfect, but it really is a historic time where we're really starting to see some real movement in being able to share healthcare information electronically between electronic medical record systems, even disparate different systems like Chip mentioned, really leading to better collaboration between healthcare providers. So now ready to transition to the last case study.
Thank you, Dr. Merrill and Chip. Appreciate that. Our third case study involves the delivery of hospital information to the post-acute setting, which would include skilled and long-term care facilities. And we have this morning Steve Albers, the Chief Technology Officer, and Emily Jones, an ambulatory consultant with Wellmont Health System. I think Emily will do the presentation. Yeah.
Good morning, everyone. Our third case study this morning that we'll be reviewing is direct messaging with local long-term care facilities. We're going to review the technology that allows a message to be sent to an outside organization, the vendor that Wellmont's using to accomplish the direct messaging, the workflows involved in sending direct messages, what information is shared via the direct messaging, who Wellmont is sending direct messages to, how those organizations consume that data, the future of expanding direct messaging, and the benefits of direct messaging for patients and providers. In order for Wellmont to send direct messages to recipients and organizations that don't use Epic as their EHR vendor, we utilize a HIS. A HIS stands for Health Information Service Provider. A HIS is not specific to one organization or one medical record brand. The HIS allows for data to be transported securely using the direct standards. A HIS can be thought of a lot like an electronic post office. Thank you, Dr. Lefkowitz, for that suggestion. The HIS can interpret the direct address to determine if it's a local address, if it's going to be delivered within its own HIS, or if it needs to be sent to another HIS so it can be delivered to another organization's EMR. Next slide. Wellmont selected MedAllies as our HIS as they provide us with the assurance that the direct address is correctly linked to the provider or organization that we want our patients to follow up with, along with the security of certified encryption, all while meeting the established direct industry standards. Next slide, please. So now that we've determined our HIS and we can send direct messages from Epic, Wellmont needed a way for our local long-term care facilities, rehab centers, and rural health organizations to be able to view our direct messages. MedAllies provided a solution for this challenge with their MedAllies mail service, a secure mailbox designed to receive direct messages from Wellmont or other healthcare organizations. The secure mailboxes allow for authorized users to be able to log in to retrieve the direct messages that contain information in the CCD format. Logging in on MedAllies mail is similar to logging into a web-based email system like Gmail. The user can log in from any computer, and they can open their organization's shared inbox to access patient information. Next slide. This is how the summary of care appears to the long-term facility staff when they log into MedAllies now. I know the graphic's small, but the data is still presented in the same standard CCD format with the patient demographic information listed first, followed by the referring provider, progress notes, plan of care, and recent results. Next slide. The general workflow for sending direct messages begins during the discharge process. The patient's case manager identifies which organizations the patient is following up with. The case manager then sends the summary of care message. The summary of care message is sent into the HISP. The HISP routes it to the correct recipient, and then the direct message is received by the recipient via a secure messaging system. Next slide. For Walmart, we're using Epic, and the case manager opens the patient's chart, and then from the communications activity, selects to send the summary of care as an outside provider message to the location that the patient will be transferred to, either a long-term care facility or a skilled nursing home. Or, if the patient is being discharged home, a rural health organization can be selected for follow-up care. This is a summary of how the outbound direct message flows from Walmart to a nursing home, rehab facility, or rural health organization. You can see that the message is sent by Walmart via Epic into our HISP MedAllies, which uses direct protocols to deliver the information to the secure mailbox in MedAllies Mail. The receiving organization's authorized staff then accesses the secure mailbox to receive the information and messages from the patient's summary of care information. As stated in the previous case studies today, the direct message contains the summary of care information in the standard CCD and CCDA format, with the patient's name and demographic information listed first for easy identification, followed by active allergies, current meds, the problem was, the patient's most recent appointment, immunizations, histories, vital signs, progress notes, plan of care, recent lab and imaging results, and their PCP's information. Next slide. This is how the summary of care appears in Epic. The allergies, current medications, and problem lists, the data that are able to be discretely consumed into Epic from a PCD are listed at the beginning of the document. Currently, Walmart is sending direct messages to local skilled nursing homes, rehabilitation centers, and rural health centers that have been configured in Epic and have signed up to use the MedAllies mail service. Walmart case managers will reach out to the local nursing home or rehabilitation center prior to the patient's discharge. So the message received in MedAllies is used for the confirmation of the patient's follow-up orders. When the facility's admissions director or designated staff logs into MedAllies Mail, they're able to print the summary of care to either add to their paper chart or they can scan it to their own EMR. Next slide, please. Direct messaging is not just limited to a push of information from a hospital to a long-term care facility. As more healthcare organizations' EHRs connect with HISP, direct messaging can expand to a bidirectional push and pull communication to allow for greater patient information reconciliation between EHRs. In the future, providers will be able to push messages to other providers and hospitals. Providers will be able to pull information from the hospitals and clinics where their patients have been seen, and hospitals will be able to pull information from other hospitals, clinics, and providers. With our local long-term care facilities having access to our summaries of care via direct messaging technology, Walmart is able to support our providers in meeting meaningful use requirements, along with improving communication of the patient's current health status through the exchange of information as the patient transitions from the acute setting to a skilled nursing care facility, rehabilitation center, or a rural health organization.
Okay, thank you. Appreciate that. So we've looked at 3 different settings of care and how information is being transferred. And Dr. Lethbridge is going to kind of wrap this up for us and talk about a few other items related to this topic. Dr. Lethbridge?
Thanks, Martha, and thanks, everyone. Those were excellent presentations and great insights. And I like Dr. Merrill's observation that this is really a historic moment. Because if you look back just 3 or 4 years ago and said that we would not only be able to do this, but be doing it across the country and in a lot of communities, I don't think it would have been believable. But it is possible, Northeast Tennessee, and our hope is that with the community collaboration on care coordination, we'll be able to expand the number of providers and settings of care that are engaged in this information exchange. The slide on your screen right now is a graphic of the spectrum of care. It's gotten much more complicated than it was when I started my career back in the 80s. There are a lot of places that patients go, that individuals go when they've been in one setting of care and move to another. And as you're well aware, the more complex patients spend much of their time on the right side of this spectrum of care as it's displayed here. If I could have the next slide, please. There are, in fact, 14 places to go from one of the other 14 places. But the key message here is that they all really need the same basic data about the patient. And high on the list of priorities is that data gets there when the patient does in order to enable care coordination and to prevent patient safety issues and improve outcomes. And it does really make a tremendous difference just having that information. We've heard this morning about how it's possible to exchange between electronic record systems, but it's also possible for settings of care that don't have an electronic record but do have an internet connection to get this same information in real-time fashion from the electronic record system that can produce it and send it by direct secure email exchange, and all the other setting of care needs is one of those direct accounts, which are not prohibitively expensive, but do enable the information to get to that setting. So the next slide. What you've heard about today is the combination of a technology network and a community network to enable care coordination. And as you heard at the beginning, a few months ago, we set out on a community initiative that we've named the Community Collaborative on Care Coordination. There were two town hall events earlier this year in which a number of local providers and people involved in healthcare made a commitment to join an effort to form work groups and work on improving care coordination in Northeast Tennessee, particularly with enabling technology and agreeing on plans for best practices and workflows and sharing contact information, which is sort of the first key point. And as Trish mentioned earlier, one important thing is to actually attribute the primary provider to an individual so that the setting of care knows where to send the information. That's very important, and as we've learned in some of these projects, that's often as much of a challenge as the technology itself. So all of those who are listening and are interested in joining in this effort, and I hope most of you will be, we do have a contact address, but I don't believe it's on any of these slides. Can someone on the call provide that email address for the Community Care Collaborative?
Michelle, do you have that available?
Yes, sorry, I was on mute. It's care, COORD @yahoo.com.
Okay. NETNCARECOORD
Yep, @yahoo.com.
yahoo.com. Or otherwise, if you have an email address for any of us, we will be glad to help connect you to that effort, and would welcome your joining in this collaboration to improve care. You can also watch your email box as we do plan a series of webinars that will address the issues that are the starting points for these care collaboration, care coordination efforts, and we look forward to you joining those webinars as well as our efforts. So thanks, everyone. Thanks again for the excellent presentation.
Thank you, Dr. Leffers. We have a few minutes still left on our time. If there are any questions out there, please ask them now. If there's somebody particular you want to address it, just let us know. But I'll open it up now for any questions from people who are on the webinar.
I'm curious, this is Jeff Merrill. I'm curious for the Wellmont team on the call, you know, what your experience has been with the long-term care facilities as far as, you know, are you having pretty wide participation with them getting them on board with, you know, the exchange of information?
We've had approximately 20 different organizations sign up to use the MedAllies mail service so that they can receive messages from us. So they're all locally within Kingsport, Johnson City, Bristol, and Abingdon primarily.
Is there any cost to those post-acute facilities, you know, to be part of that MedAllies solution?
At this point, Wellmont is sponsoring that. There's no cost to them. Now, if they choose to send information back to us, then they would need to subscribe. But we're funding the annual cost for that. It's fairly minimal. There's not much expense associated with it. But right now, we're paying the cost of that.
This is Russ Lethbridge. Experience with other similar direct mail services is that an account, a single direct address webmail costs on the order of $150 to $200 a year. So it's certainly not prohibitive. It's not free email, but it's reasonable, I think.
How long have you all had that MedAllies solution up and running and, you know, connected with some of these facilities?
It's been about 2 years.
Do you have any data, you know, to show that you know, your readmission rates since that's been turned on? I'm sure you're doing many things at the same time, so it may be hard to tell kind of what's causing what. But do you have any data to suggest that, you know, decreased readmissions, lower cost of care, et cetera, has resulted from those connections?
I can't really say that we have anything specific. I will say that since we're more connected, there's better communication between the nursing homes and the facilities, especially with information being available to the ED. So I think it does have an impact, Dr. Merrill, but I can't say that I have any specific data tying it together.
Yeah, I realize we're all kind of early in the game, but very interesting. Great job with the different case studies that were presented today. You guys did a fantastic job.
Thank you. I agree that everyone, a lot of times we don't even know what's going on in our own region. So I think this is benefiting all of us to realize what everybody is doing and what capabilities we do have just within our region. Any other questions or comments from the listeners? Well, I want to thank everyone for participating this morning, both the presenters as well as those of you who have listened in today. Again, as Dr. Lefferts said, we hope to present a number of webinars that will benefit all of our providers. Please watch for notices that will come out. And we will be posting this. We'll make that available so that others who maybe weren't able to listen in today will be able to view it later. And we'll get that information out on where it will be posted. So if there's nothing else, I want to thank everyone, and everyone have a great day.
Thanks, everyone.
Thank you.
Thank you all.
Thanks.